I'm Rosalind Diancelli, the Vice President of Clinical and Medical Affairs.
And I'm Rich Lowe, Vice President of Marketing. At Sientra, education has always been at the forefront of everything we do. As the only breast implant manufacturer to sell their implants exclusively to board-certified plastic surgeons, facilitating peer-to-peer education is critical for our success, we think for yours, and ultimately for the best patient outcomes.
Sientra is a responsible partner to board-certified plastic surgeons. We continue to promote sound science and education on important health topics. This video is another step in our ongoing commitment. We would like to thank Drs. Adams, Calobrace, and Diva for their leadership and contribution on this important topic, and we hope that it will benefit your practice and, most importantly, your patients.
Welcome everyone for another Sientra Roundtable. And I think today may be one of the most important roundtables we've done in a long time. We're going to talk about the concept of bioburden and infection as they relate to breast implants and the 14-point plan that was outlined by Bill Adams and Dr. Diva, who I have both of those with me, both good friends and experts in the field. They've been working together for 10 to 15 years. And we're very happy to have Anand Diva by satellite here from Australia to join us. Tell us, Anand, why would plastic surgeons want to hear about biofilm and bioburden when it relates to breast augmentation?
Well, thanks, Brad. Infection is one of the biggest problems we face in surgery, and prevention of infection is something that goes right to the start of surgical practice. What we know now is that with prosthetics, they can become contaminated with bacteria, and once bacteria attach onto the implants, it becomes irreversibly attached. There's a growing body of research showing that device-associated infection, in fact, is the leading cause of implant failure and reoperation in our patients. And so what we do as surgeons right at the beginning has a massive impact on the likely outcome and success of these implants long term.
Yeah, that is the point, isn't it? So we also have Bill Adams with us here in Dallas, Texas. So tell us, Bill, from your perspective, U.S. surgeon, tell us, why is it important?
We've learned now through a lot of science that bacteria are bad and more bacteria are worse. And so there are now defined techniques that we can use to reduce the bacterial load around implants, which have been proven to reduce various different issues that we know bacteria cause around breast implants and other implants. This is actually a way that surgeons can actually differentiate them and their practice from other people, because adopting these simple techniques, it's very easy to do. Patients like to hear that. They want to know their doctor is going to do everything they can do to optimize their outcomes, and that's what this does. So it's going to be great to walk people through the details of how to do that.
First point of the 14-point plan is the use of intravenous IV antibiotics. Anand, why is that important?
There's a lot of research that shows that a single dose at the time of anesthetic induction can reduce the risk of surgical site infection significantly. Now, people often ask us what's the best to use, and we recommend something that is targeted against Staphylococcus epidermidis, which has been shown as the leading cause of contracture, and so we recommend a first-generation cephalosporin.
It's a well-known surgical fact that perioperative dose of antibiotics in these type procedures is beneficial, but I think it's also important to remember the issue is a polymicrobial problem in, say, capsular contracture, but also for other untoward effects of bacteria with breast implants. And so you want to have broad spectrum coverage. A first generation cephalosporin actually has some pretty good broad spectrum coverage, but it's also important to keep in mind that there's other steps that we're going to talk about that deal with bacteria. So in the worst case scenario, say you're using a first generation cephalosporin and there's a bacteria that's not sensitive to that first generation cephalosporin, the other steps are going to take care of that.
Exactly. And I think the whole concept is really to reduce the amount of bacteria that get on the implant and into the pocket, because some of the long-term effects with it. And the second point of the 14-point plan, speaking of that, is maybe avoiding the periareolar incision when doing this. Why is that, Bill?
Yeah, so there's been some very good studies to show that in the periareolar incision really is the one that's been implicated in a higher rate of capsular contracture. In fact, 8 to 10 times higher because of this bacterial load, implants going through the breast tissue, there's more introduction of bacteria around the implant, and that's why people have seen an increased rate of capsular contracture. Now, there is some data to say that there also is an increased rate of capsular contracture with transaxillary, but there's also some transaxillary data that suggests that it's similar to inframammary. If you're going to use a different incision type like transaxillary, you just need to make sure you're doing everything you do to minimize that bacterial load.
Anand, don't you think that that's what's unique about prosthesis or breast implants as they relate to implantable devices, is that we are placing them through and into what would be considered a contaminated field, which is unlike where other prostheses are placed, like joint replacements?
Yeah, absolutely, Brad. I think, as plastic surgeons, this information is actually really critical, because we're putting an implant into essentially a contaminated pocket. I mean, we know that the breast ducts are full of bacteria, particularly postpartum as well. And so this step 2 of the 14-point plan, I think, as Bill says, the submammary allows you to directly visualize what plane you're in. It also minimizes the amount of, the chance that you cut inadvertently into the breast tissue and spill bacteria. Now, the periareolar, by definition, goes through breast tissue, so you're once again actually putting the implant through not just skin, but through contaminated breast tissue as well.
Yeah, I think that's it. Speaking of contamination, the 3rd point talks about the contamination that can occur during the case from nipple discharge. Anand, tell us about that.
Manipulation of the breast during surgery actually results in release of fluid through the nipple ducts, and from that fluid you can culture a lot of bacteria. So it makes sense to put a barrier across the nipple so that during your manipulations during surgery you don't have this fluid drain down into your surgical base.
So I use a nipple shield to protect the operative space even before I prep. What do you do, Bill?
Yeah, this is a very simple thing, but there's been several really good studies to show that there's bacteria in nipple ducts. And again, just thinking in terms, we're never going to totally sterilize that breast implant pocket, but what we're trying to do is reduce the amount of bacteria. There's bacteria in the nipple ducts, so if we can barricade that just with a simple, I use a Tegaderm, but whatever kind of barrier you want to put on there, it's an inexpensive, easy thing to do, and so we do it in every case.
Most surgeons I talk to are using nipple shields and have gotten the idea that the nipples can actually contaminate the field, which I think is something we didn't appreciate in the past. The 4th point is careful atraumatic dissection during the surgery. The next few points are really about surgical technique and how that can help reduce the bioburden.
Points 4 through 7, performing careful atraumatic dissection to minimize devascularized tissue, performing prospective hemostasis, avoiding dissection within the breast parenchyma, and then using a dual plane or a partial submuscular pocket. Those things all go hand in hand. Those are not unique to this particular subject. Those are things that we've both been teaching for many years to surgeons. It's about being precise, being atraumatic, doing things under direct vision, minimizing bleeding within the pocket. All those things increase the bacterial load within a pocket. So these are just surgical tenets which are very good that will help reduce, again, the amount of bacteria around the implant, and in the greater scheme of things also are a better way to dissect a breast implant pocket.
Anand, do you have anything to say about surgical technique?
We need to draw attention to the fact that the operation of breast augmentation has undergone some significant changes. I mean, Bill and I are old enough to remember the bad old days where urethral sound was put in, the implant was popped in, and 10 minutes later it was all over. And of course you came back that night to drain the hematoma for your boss. So these surgical techniques, I mean, Bill is a great advocate for good surgical technique, have made, I think, probably contributed to a complete reduction in the sort of post-operative complications. And we can't take away from that. And that's why we put them into the 14-point plan.
Yeah, I agree. And I think, when you think about blood, that's why it's so important that you don't leave a lot of blood there. Or if you have any kind of a bleed or hematoma, we know that when you leave that blood there, it increases the risk of capsular contracture. And it may all be tied together as it relates to food for the bacteria, so to speak, in that pocket. Number 8 is one we talk a lot about, and there's been a lot of discussion over the many years. Perform pocket irrigation with triple antibiotic solution or betadine. So, Bill.
Yeah, so this is something that's been evolved over the past 15 years, but this was a polymicrobial problem, not just Staph aureus. So again, if you're going to use an antibiotic irrigation, you want to use an irrigation that has the best polymicrobial coverage. When we did our antibiotic irrigation studies, we looked at those different irrigations, and what we found was actually a lot of my professors I was working with were using a lot of solutions that didn't cover any of the bacteria. And so those studies have defined what are the proven irrigations to use around breast implants. And they're really specific recipes that should be mixed up properly in order to give that coverage. And so there's a triple antibiotic betadine containing irrigation at 50 cc's of betadine, 1 gram of cefazolin, 80 milligrams of gentamicin, and 500 of normal saline. There's a non-betadine triple antibiotic, which is 50,000 units of bacitracin, a gram of cefazolin, 80 of gentamicin, and 500 of normal saline. And then you can also use betadine, but the important thing to remember, the betadine needs to be 50% or stronger strength. So out of the bottle it would be 100%, so you can dilute that 1-to-1, but no more than that, or else it doesn't even work against staph epi, let alone a lot of the other bacteria. These irrigations now have been shown, certainly by our studies, but by other studies, Giordano, Blunt, to have 10 times lower capsular contracture rates using these specific solutions. So our recommendation to surgeons is to use those solutions specifically, make sure they're mixed up in the proper proportions, because we have now proven solutions that they can use that we know work.
I think this is probably one of the most important steps in the 14-point plan. I think betadine is one of those things that we've worked in the laboratory for a very long time, and there's actually nothing that is actually resistant to it when it's used properly. So I think use it properly, read the formula, mix it up properly, and then you're actually doing proper pocket irrigation.
The ninth one I think is almost equally as important, and that is the concept of minimizing the skin to implant contamination or contact. Anand, do you want to talk about that?
Yes, look, there's many different techniques, but I think Richard Maddock was the one who first talked about an introduction sleeve empirically to reduce the implant touching the skin and the subcutaneous tissue, and in fact probably the breast tissue as well as the implant goes into its pocket. And since then we've had the Keller funnel. I use a simple cut-off glove technique. It's just some way of preventing particularly textured implants from rubbing and frictioning across the bacteria on the skin, subcutaneous tissue and the breast tissue. And there's some evidence now, preliminary clinical study, that's been shown to produce over a 50% reduction in contracture following the introduction of a sleeve. So I think that the important point here is that each of these now is backed by good laboratory and or clinical evidence, and therefore I think this is a really important one, particularly if you're using textured implants.
Bill, what are you using?
My personal technique has always been to wipe the skin down with a fresh antibiotic solution, irrigation solution, so gauze pad, and then insert the implant. But all the different things mentioned are all ways to minimize skin implant contamination.
Exactly. Included that, number 10 is really about minimizing the time the implant's open.
Yes, and that is something that sometimes people just don't think about. The natural thing is to take the implant, the nurse opens the implant, and it's just sitting on the back table for an hour or an hour and a half, and that's probably not the best way to do it. So again, simple things, but we take the implant, we don't open it. We do open the implant slightly and squirt some antibiotic solution onto the implant. Actually, there's some data to show that reduces the negative charge around the implant that can attract different foam mites and other things on the implant. So we leave that there until right before we're going to insert it, and then we can peel the thermoplast container back, and then the surgeon is going to handle the implant and insert the implant. But again, just minimize the times you're putting something in and out, because the more you do that, the more that bacterial load is going up, and there's this battle going on between your body trying to keep the bacterial load down and the bacteria trying to keep the bacterial load up.
And I'm even more so than sizers is some patients put in the real implant they're going to use, but they don't think the pocket's the right size. They pull it back out, they put it back in, check it, pull it back out. Yeah. And I think those are things, that's the implant you're going to use, and every insertion and removal is just repeating the contamination. Anand, do you have anything else to say about that process?
So going to our orthopedic literature, certainly over an hour into surgery, there've been sampling of surgeons' gloves and the operating nurses' gloves, and about 27% of them have got staph epi on them. Just because we're handling skin, we're touching skin. In one study, Beldane published, and this is in the literature that you can access, contaminated staph epi actually found its way onto the prosthetic as well. So you've got a direct route from long operations. So once again, minimizing the time of stuffing around in the operating theatre actually has an impact on infection, and then a direct route from contamination of gloves to prosthetic. So this is, I think, once again, they're all important points, but all these things work against you ultimately. So you've got to be aware of it, you've got to be thinking about it, you've got to remember to do it.
Yes, and that is the 11th point of the 14-point plan, which is changing surgical gloves and maybe dipping the gloves in the antibiotic solution to reduce contamination.
Simple to do, but a lot of times you'll see various people in the operating field handling an implant. That's not a great idea. It should be just the surgeon that handles the implant with a brand new set of gloves. I know there's different things. We tend to clean all our instruments within the antibiotic solution. So anything that's going to go into the pocket needs to be, once it's prepared and irrigated, whether it's the surgeon's finger, it needs to be clean. You can dip it in antibiotic solution. Always just put a new pair of gloves on, place the implant. I know Anand actually uses a brand new set of instruments, but again, you don't want to reintroduce, prepare the pocket and then reintroduce a big load of bacteria because you didn't think about that.
Right. Anand, the 12th point is the use of a layered closure.
Yeah, so once again, there's to put things back anatomically, to reduce dead space, to restore the fascial layer. This is once again just good surgery, isn't it? Making sure that the wound has, you've completely sealed off that pocket from externally, from breast tissue and from skin.
Kind of getting that watertight seal from the implant to the outside world. And so I think a deeper layer than just the skin. Sometimes people are just closing skin, and that's probably not the great way to do it. So a layered closure with closure of that superficial fascial layer.
I think this one's interesting. The 13th point is avoiding a drainage tube.
Yeah, this is one that has raised a few eyebrows. I know some of my colleagues use drains routinely. I think the important thing is if you are going to put a drain, it shouldn't be left in for a long period of time. You might say the drain is working to remove heme and fluid around your implant. It is also acting as a conduit to allow bacteria to go directly into your pocket. So for me, I don't use drains in primary cases. Certainly in revision and reconstruction cases, yes, I do use drains, but I make sure that the drains are not left in for too long. And certainly there's an argument, and we're looking at this at the moment, as to when you have a drain in, that antibiotics probably should flip from a prophylactic to a therapeutic or a longer course post-operatively.
I use drains in revision surgery quite a bit, reconstruction. I don't use a drain in primary augmentation. I think that's been fairly well proven, but then that's again using the other tenets we talked about. If you're using a drain in primary augmentation to remove blood, then what I would say is go back to steps 4 through 7, because you're probably maybe doing some things that you could minimize the blood that way, and then you don't need the drains.
And then finally, the 14th point of the 14-point plan is really about the concept of using antibiotic prophylaxis post-operatively, down the line when somebody has some sort of a procedure or anything that invades the skin or the mucosa. Bill, you want to speak to that?
Yeah, it's probably the one step that has the least scientific backing, but clearly with the bacteremia you can get bad events with the breast implant. I've seen a patient with otitis media that gets a breast implant infection. I've seen patients who have had a dental cleaning and then subsequently get a capsular contracture. So there's clearly an association of bacteremias. Dental cleanings are probably the most common things for most people that clearly they get a bacteremia. And so it's been our preference to prophylaxis people with just some penicillin or clindamycin at the time the dental cleaning, just for the couple doses. It's very inexpensive, has very minimal downside. We practice it. We just give that prescription to the patient at the time of their surgery. We go over it with them. They know about it. It's really been a minimal issue. We haven't seen any issues with it, and so I think it's something we'll continue to do.
As we said earlier, we're putting breast implants into a contaminated pocket to start with, so we're already behind the 8 ball as compared to some of our other specialties that are using implants into cleaner spaces, I should say. So once again, it's easy to do. It's a matter of just informing your patient. There's good evidence and there is good, thought and biology behind this recommendation. And until we have better evidence, this is certainly not something that's really harmful.
I think that the 14-point plan, I think the real concept is we need to take a better understanding and a better appreciation for the fact that bioburden and contamination of the implants has real long-term impact for the patients with these implants, and that we need to be more serious about it. And the 14-point plan is a place that a surgeon can turn to have some really good recommendations. It's not a rule book. It's sort of a guidelines to help them do better at reducing that contamination.
Yeah, I think most of these are really simple. They're very inexpensive, but they're things that we put together that have been proven to improve the outcomes for patients and reduce that bacterial load. So I think adopting these into a process that you do in every patient is a no-brainer.
Yeah, I agree. It's good medicine, I think. Let us just review one more time the 14 points to this very important plan for reducing contamination when placing implants. final word is to you, Anand, from Australia.
Thank you. So look, I think once again, all that Bill and I are asking for is for our colleagues to become aware of the issue of infection when you're using a breast implant. A lot of what we've discussed is actually now on the web. It's www.saferbreastimplants.org. It has all the articles that you can download. The other thing it does is it encourages surgeons to take a pledge to support the 14-point plan. It's once again not being prescriptive. It's simply to get an awareness of the importance of biofilm mitigation. This is all about improving patient outcomes through good research, translating research into clinical practice into benefits for our patients.
Thank you. I think anything that benefits our patients is great medicine. And I'd like to thank Sientra Roundtable, Dr. Adams, Dr. Diva from Australia for joining us.